We're going to start. Welcome back. Did you have a good lunch? Enjoyed your lunch? Yeah, so the last conversation before lunch, I must say, was quite juicy. In a way, so I'm looking forward to adding, to us adding to that juiciness, because it was really an interesting, fascinating conversation. I left feeling conflicted because the presentations and just the discussion made me think, there are actually not so many options for, and at the same time, we want to remain hopeful and we want to find, new avenues to do the work that we do. So I'm going to hand over to Adila because she had already started to say, hey, we need to know where to from here. And she's going to focus her presentation, and will be all ears, Adila, I can tell you that, on how can health taxes fill the gap. And, you can build whichever way you want from the previous conversations for the sake of continuity and just bringing more insight. And then we can open this discussion up to where to from here. After Adila's presentation and the conversation we're going to have about where to from here, we're going to ask Wiseman Makasela to just, also talk about what are some of the key takeaways from these conversations that he has identified, adding to the conversation around where to from here. And we will end with Mapalane Mfundisi, who will close us out. So over to you, Adila.
Thank you. And I hope you all enjoyed the conversation that went with lunch. I'm going to talk about, I've been asked to talk about health taxes, and this is not my own work, but rather it draws on a resource that I think that would be useful for everybody to read, that was produced by Vital Strategies. Next slide, please. So I start the conversation by saying that SAPA, the Southern African Alcohol Policy Alliance, essentially have embraced the issue of increased excise tax on alcohol. And this is because, and I think the previous moderator left the room flabbergasted by the cost of our debt or servicing our debt. The cost of alcohol harm to country annually is between 10 and 12% of GDP. Last year, that worked out to 800 billion rand. We lose 100 people every day due to alcohol-related harm. And this harm spans across health and social harms. So I'm not going to go into detail to that, but that's the background. So 2 weeks ago, a week before budget speech, we marched onto Parliament asking government to increase the excise tax on alcohol. And we used the issue of bread and beer. A lot of people don't know this, but beer is cheaper than bread in this country. And I hope in the room I'm getting people to go and Google, because that's often the response, is that really true? But that is the truth of the matter. Next slide, please. So I'm just going to very briefly reflect, and as I indicated earlier on, that most of the issues that I wanted to talk about and raise was already discussed in the sessions in the morning. Next slide, please. But I think a key issue that we need to come to terms with, is that we should refrain using the word sin tax. That excise tax, or as we would like to frame health tax, is a tax that's a tool available to all governments. Next slide, please, so I can just talk to that. It's available to all governments, 1, to protect and promote public health, and 2, to generate sustainable revenue. That the notion of, or the very, at the heart of excise tax is that it acknowledges the disproportionate harm of products like tobacco, alcohol, and sugar-sweetened beverages. And that the purpose is to help correct market failures by ensuring that the broader social and economic costs of disease, disability, loss of productivity are reflected in product prices and thus promote equity. I think Salome very specifically asked us, and I think Mohammed also, the issue around what does equity mean for us? And we see health tax as one way of beginning to address that. Next slide, please. So what's the health tax proposition? That if you increase tax, you will have higher prices, you will lower consumption, and therefore you will get better health. Next slide, please. And the key thing, and I think earlier on, the question was, what evidence do we need to put forward to Treasury to begin to engage and shift the conversation? And the key issue is that for us to win the issue around taxing or health for tax, tax for health, sorry, is that we need to put to forefront the health rationale, that we constantly need to use evidence available to us. Next slide, please. And we have that evidence available to us. We've got burden of disease stats, we've got healthcare costs, we've got productivity loss costs, we've got deaths, and we have information on the potential deaths that could be averted and disease burden that could be reduced if we looked at tax as one of the potential ways of reducing the burden on the country. And there has been several studies, different people, the SAMRC, the UCT REAP, economics unit, Rashad has been involved in some studies that we need to use to make the argument for health taxes. Next slide, please. It requires modeling, and again, I mean, this is not what is not our work, or what I'm reflecting is what we require to do in order to use health tax as an instrument for addressing health equity. And we are able to gain several things by looking at modeling as one way of gaining evidence. Next slide, please. I'm not going to go into it because it's been discussed in the room. And there's different ways in which that could be done. Next slide, please. Well, I think that's, for us, the key issue is that we constantly have industry arguing against health tax, excise tax. The louder they shout about excise tax, the more comfort we should gain by the fact that we're on the right track. It makes them uncomfortable because, next slide, please. Because what health tax does, it's a direct threat to their profit margin. That health taxes increases prices, it reduces consumption, it can contribute to reducing consumption, and therefore sales, and therefore is a threat to their profit margin. Next slide, please. But there's a playbook that the industry uses, and we've seen this across tobacco, alcohol, sugar, sweetened beverages, that they use to argue against health taxes. One, they question science, and they introduce their own pseudoscience into the narrative. They undermine, particularly the World Health Organization's recommendations, that they push for voluntary guidelines, that they don't want to be regulated. And I think that we need to, for us in working the alcohol space, this is a particular issue that the industry continuously push back against any regulation. That, again, reflecting on our alcohol experience, is that they blame the consumers. That, and I'm sure all of you have been exposed to the advertising that pushes responsible drinking narrative. What that does, it places the emphasis on the individual to take responsibility for their own behavior, rather than looking at what are some of the structural issues that needs to be addressed to impact on the choices people make around drinking. During COVID, we saw them using lawsuits in particular. They deploy front groups. And I think for all of you working on NCDs, that they do pretend they are not targeting children. And that the biggest issue is that they push the job loss narrative, that if we increase taxes, it will impact on jobs, that they would have to make choices. But that very job loss argument is never acknowledged when they make their own internal decisions, when they introduce a mechanization as an example. Next slide, please. Sorry. Oh, I sent you the wrong slide. Show. So what, do you mind if I share from my side?
Go ahead, it's fine.
Okay. There's a few slides missing. Let me just do this. You're able to see?
Yes, yes, we do. We can see. Yeah.
I need to go to.
Yeah. If you can please put it on presentation mode, that will be helpful.
You can see that?
Yeah.
So as SAPA, we, as I said, we decided to promote the idea of increased excise tax as an important tool to government to address the harms of alcohol in the country. This is a image that we have using that our country and our roads are being flooded by alcohol, just based on our understanding of the statistics and the conversations we have with communities. As I said, we use the analogy between the cost of bread versus that of alcohol. And I hope this will spark some conversation in the room. The key thing, and I think I really appreciated Muhammad's emphasis on community and community participation, is that we have entered into partnerships with communities through, as well as we have decided to have a partnership with the National House of Traditional and Khoisan Leaders. They currently represent about 1/3 of our population. And I think it is an underutilized partnership that we've used in the health sector to begin to address issues that affects communities in all over the country, but also particularly in rural communities. In our process, we in advocating for increased excise tax on alcohol, we targeted policymakers, and so we had something what we called message in the bottle, where we put in facts on alcohol harm, and we did a survey around what's the perception of taxes amongst just over 1,000 people in South Africa, and what they would support. As all campaigns, we identify champions, and that we are engaging with committees, the different parliamentary committees on this issue. And then we have looked at media. And I think the one under-resourced media tool that we've not really used is that of sponsored media. We see the alcohol industry use that all the time. And the thing about sponsored media is that you can't have anybody writing an objection to it. And so we've very specifically included that in our strategy to put things on the table with regards to alcohol and alcohol harm. And we've done this across different media. We've had several, we don't have to talk about this, but we've used different media platforms, from traditional to social media, radio. I know that in the room you have Lucille from CMT, and we worked with for our campaign. We have engaged social influencers in promoting this issue around using taxation for health.
You are breaking. I think our connection is not that good. So just so you know, we are missing a few words. I don't know if you can hear us.
I can hear you, and apologies if there is some connectivity issues.
Yeah, but, the last word we heard from you was around using influencers.
I think for us, part of the lesson is that you have to put that into the mix of any campaign. You have to be careful about how you use influencers and how you select them. And they need to align to your own Abul Hanifa. So you have to be careful about alignment. But I think that by sharing that, I want to just go back to the conversation before lunch, because I think that was the thing that I thought that we needed to pick up on. And the one thing that Salome raised was the issue of what is civil society's role in the oversight of allocation of budget, which I think we need to take up as a collective. The second thing, and I'm not sure if the Treasury person is still in the, I found it very interesting that he acknowledged that in some cases there's been ring fencing, but when we raise ring fencing as civil society, there's often this pushback from Treasury to say that it's not something that they favor. The question is, how big must the crisis be in order for Treasury to consider this as an issue? And when we talk about ring fencing, I think that we're not talking about ring fencing the full tax revenue, but rather can we talk about a percentage of the tax revenue raised that can be allocated for health promotion and prevention. The third thing was that of, I think the person from the diabetes community raised the issue around an NCD conditional grant and whether or not that is something that we collectively should be talking about and advocating for. I mean, the last thing perhaps, and just, I guess it was emphasized in the session, was what's the data? How are we using the data to put forward the argument for a health tax? And I think central to that is what is our collective action? And again, Salome raised the issue of operating in silos. If we are wanting to push for an integrated approach, what does it mean for all of us to step out of our own house, our own silo, and to begin to engage as a health tax alliance, collectively pushing for taxation as part of the package? It's not a silver bullet, but it's one of the key interventions that has been argued for internationally that can begin to address our burden of disease and cost to country. So I just want to stop there.
Great. You've asked, I guess, the fundamental questions for this session. And I don't want to put Jonathan on the spot here and make this about just Treasury. But I would appreciate that you do answer some of these questions because, especially around the ring fencing question that she asked, how big a problem, does it need to be, for a different approach to emerge, as well as, the collective action that needs to happen. So one of the things that happen when civil society advocates and when it has used certain strategies in the past that have worked, and they are now advocating on a different issue and the same strategies of the past are not showing similar results, at times we find ourselves stuck. And I think there is a challenge that needs to be thrown back to civil society about what is it that needs to be done differently going forward to address some of these issues. So I'm going to open this up to you for more questions, for more input, and let's make this conversation really be about what can be done differently, what can be reinforced, and how do we move this work forward. Who would like to start? I'll just open it up before Wiseman speaks. Any contributions? Would you like to say something?
Can I just ask one more question?
Okay, go ahead.
How do we hold the Department of Health accountable for non-expenditure? To know that there was a budget allocation from the HBL that was allocated, that was unspent, and that resulted in a reduced allocation the following years is I just don't know how to respond to it. And so the question is, how do we as civil society begin to be involved in performance management of the very departments that we support? Because the work that we do at community level is meant to supplement, not to actually do what they're supposed to be doing.
Jonathan, do you want to just respond to?
Yes, I can respond. No, thank you. Thank you. First of all, thank you very much for the interesting presentation. I don't work on tax policy, so I can't really speak in too much detail on the ring fencing issue. But maybe just to clarify, what I said in my intervention was that it's it's extremely rare that we do it, and I can only think of 2 cases where that's being done. And if I'm not mistaken, those are cases where there is specific legislation that links a tax to a specific purpose. So, for example, there's a portion of the the fuel levy that, in terms of the Road Accident Fund Act, if that's the correct legislation, needs to be allocated to the Road Accident Fund. And I guess similarly with the UIF, that there's specific legislation that links a levy to a specific institution. But aside from those very, very unique cases, there is no, as far as I know, ring fencing of tax revenue, specific tax revenue sources for specific expenditure area. I think beyond that, I can't really comment because I don't want to speak on behalf of my colleagues in tax policy that are not here. Regarding your other question about holding the department accountable, I think it's really critical one, and I think I mean, it would be good if the civil society can do that, engage with the department. I mean, we've seen now since the revenue or the levy was introduced, and we introduced these allocations for quite a few years, not that there's been poor spending in that allocation, and we've raised it regularly with the department. Because I mean, the risk if that continues, given how many pressures there are in the sector and various areas of the department's budget, if there's an area that persistently underspends, I mean, it's very difficult to motivate to not move that funding elsewhere. I don't think that's on the card at the moment, but it is a constant concern that from our side as well. So whatever civil society can do to engage with the department on not only holding them accountable to actually spending it, but also engaging with them on how best to spend that money, I think that would be great. Thank you.
Anyone else before Wiseman? Okay.
No, thank you very much. If I may. Sorry, I should have warned you. I wasn't aware you're here. I was just asked to make a few comments, really, and I'm quite aware that some of the points that I'm going to be making, I'm actually preaching to the converted. There's a very important point that we need to start with, which we should never, ever forget, which is primary. And this point is the following. Health, people's well-being is not a commodity. If there's one thing that still redeems the African National Congress, is the adherence to that principle and value. That in South Africa, we have this commitment that health and people's well-being should not be treated as a commodity. In policy language, we call it decommodification. I've had the fortunate experience of living in another country for quite a long time and experiences from other parts of the world. Unless you suffer the experience where a family is bankrupted because of a medical episode, then you'll understand the importance in South Africa of a pregnant mother walking into a hospital to give birth and not paying a cent. You'll then understand and fully appreciate when a person is on the deathbed suffering from cancer. And if you're in one of the states of the United States of America, you're not going to be treated, you're going to die, unless you are able to have assets that you can use to go and borrow money from a bank and finance to whatever $500,000, R1 million, whatever treatment that you will be required. So we really need to appreciate this as this alliance here that is looking at even issues of tax and health promotion. So it's important that in South Africa, we have this thing that we do not want our health and well-being to be a commodity. So we are operating under conditions of fiscal constraint. Believe you me, in every part of the world where you go, there's never enough money, period. Then the big question is this: what works? And what is the evidence? And there is something as well. I was in government for 13 years as a very senior civil servant. One of the most dissatisfying aspects of what one was doing is this. You will look, say, at the past 10 years and ask yourself the question, what has my department achieved for South Africans? That becomes very important in the area of health. How much water does it take to make a blanket wet? You need to be able to know whether you're making an impact or not. When we talk about health spending since 2008 and looking at the trends that have been there, what have those trends made us to achieve as a country? So it's very important then to ask the question, what is it that works and what is the evidence? And I want to link that to the question that was made by Mohammed to Jonathan when he was asking about what kind of approach is used by National Treasury when it comes to financing community health systems. I would like all of us here to pack that question at the moment. How do we fund community health systems? And I will try and make a convincing argument from the observations of the discussions that were here, why we need to fund community health systems. The first point that is important for us to bear in mind is the following. Crisis as an opportunity. Whenever there's a crisis, the crisis always presents itself as an opportunity. When donor funding evaporates, when there's donor withdrawal, donor funding exit, it then makes us as South Africans to ask important questions. Sometimes donors want us to pursue certain outcomes, certain very specific outcomes, because they want sexy indicators. There are indicators that work for donors, but it does not translate that those indicators also work for communities. So we just need to be quite clear about that, that the crisis that we're experiencing at the moment may be an opportunity to rethink, to redesign, to realign, to remotivate some of the things that we've been doing for quite a long time. When I say that I want to focus on the issue of community health systems, this is the reason. And this is an important reason that we cannot escape. South Africa is a multi-crisis society. We live as individuals, as members of households, as communities in a multi-crisis society. Gender-based violence, unemployment, poverty, alcohol. We have the problem of crime in South Africa. We have a problem that only community-based health interventions will tell you. The crisis within families, family disruption, family dysfunction, and family breakdown that we're experiencing in South Africa. So we are a society with multiple crises. And you know, for instance, how gender-based violence, how issues of safety and security, how alcohol abuse and all those kind of things come to shape people's health and their well-being. And this, we all know, comes under the so-called social determinants of health, which we cannot escape. Now, under these social determinants of health, because now crime in the community, gender-based violence in the home, lack of jobs, lack of income, all these things add to what somebody earlier said. Where you live determines whether you are going to live. So when we take that, it then compels us to do the following. There has to be policy coherence. There has to be policy alignment. There has to be policy convergence. Health, local government, social development, education must find ways of driving towards the same destination at the same time, not at different times. So those things become very important. Please, I'm a former civil servant. When we talk about policy alignment in government, often we say, we've had a workshop with that department and another workshop with that department, and these are the things we've agreed on. No, policy coherence means going together, jointly planning and jointly going to communities at the same time together, because households need government services in different ways. So when one talks about policy coherence, we're talking about policy impact that comes from a government that works together at the coalface on the ground. So that becomes very, very important, particularly when one talks about the kind of questions that are being asked here. So when we talk about policy coherence, here we're talking about, for instance, looking at health taxes and the kind of impact that they may have. We need to be able to bring about evidence that demonstrates clearly what works. Maybe some of the allocation that comes from a health tax should be going towards funding some of the community-based health initiatives that are out there in the country. When we look at the fact that South Africa is a multi-crisis society, you cannot escape this very clear point, that is, as part of the solution, we need community-based, community-led health interventions that are located in the community, that are not clinic or hospital-centric, that bring into play the nuance that is there in the community, the dynamics that are there in the community, the power relations that are there in the community, and being able to understand and appreciate what is it that works and what doesn't work in that particular community. I'm going to share a little anecdote with you. Some years back, at some point in my life, I was acting CEO of SASSA, and we had this rather interesting outreach where we went with social development and SASSA to rural communities. So you had child and youth care workers that were helping grandmothers to apply for the foster child grant. So the foster child grant is paid. The grandmother says, "Oh, my child, thank you so much. I've got the money. Now we need to do pro-child budgeting. We need to look at the needs of the child." Says, no. You see, my child, this child's mother died, and we never did the ritual, ceremonial aspects of it. That's the first thing if I want this future of this child to be bright. So those kind of nuances at community level cannot come from a technical, very well-trained doctor who is inside a hospital. They're out there in the community. So those dynamics become very, very important indeed. So I do want to say the following. Currently, whether we're talking about our approach to primary health care, when we speak of health funding in South Africa, you cannot leave out civil society and community-based and community-led initiatives. Otherwise, it's not going to work. Otherwise, it is not going to work, because the kind of problems we're facing as a country cannot be solved through a medical science intervention model. You need a model that includes, that incorporates actors, stakeholders that are based in communities. There is work that Mohammed referred to earlier. There are instances where people in the community say, guys, everybody here at 9 o'clock, we're going to the clinic for our medication. those are community initiatives. Peer counseling. It's much easier to get young people to come together, discuss and talk about their issues and problems when they are environments that are very safe. So civil society is not just about advocacy only. It's not about the promotion of rights. Yes, as mentioned, it's also about holding government accountable. At the end of the day, it's just really honestly, governments of today are fortunate and lucky in the sense people are focused on social media, they are watching pornography, they are gambling and drinking or doing all sorts of kinds of things that just allow government to get away with anything and everything. You know, if we had an informed and active citizenry, we'll be in a position to hold government accountable. For instance, you know, it is unfortunate that for the longest time in South Africa, regardless of the amount of evidence that is brought in to argue with or against National Treasury that these things work, National Treasury still decides and opts to go whatever it is that they want to do. You know, I'm going to end by saying the following. It is odd that in a developing country, it's only the Minister of Finance who has his own budget day speech, and the whole country sits back and stands and listens to what he has to say. No, it has to be a day of social development, health, education, and local government, saying, we're going to give you the State of the Nation address. So we have it the other way around. We have it the other way around. For a developing country, it is issues about development that should be at the forefront, and the financing of that development should be secondary to the issues that are being kind of raised. But to end really, the issue of health tax in South Africa, as already indicated, there will always be a pushback. And I'm going to mention names because these are facts of the public. I was in government when Minister Mbalula was the Minister of Sports and Recreation, and we were discussing at that time the banning of alcohol advertising. The toughest questions that we faced in the social cluster were not from the alcohol industry. They're from the Department of Sports and Recreation. And their question was, who's going to sponsor the derby? What about the Carling Cup? Who's going to be sponsoring our sportsmen and sportswomen who have got to go and compete in the Olympics? So when we talk about industry pushback, it's not necessarily thinking that comes from industry. At times you find that thinking entrenched even within the very people that you expect to be advancing policies on these kinds of issues. So I just thought that I want to share that anecdote with you, that my own personal experience is that it was more than industry pushback. We actually found the language even within government itself, where people were arguing, no, there's nothing we can do without the alcohol industry sponsoring and supporting our sport in general. Thank you very much. Those are the few comments that I thought I would share with you for today.
I'm not going to spoil it. I'm just going to open it. Reactions, additions, this is your chance. Salome, I'm going to start with you online. I see your hand is up. You good?
Yes, I am. Thank you kindly, and also for the last input. I want to respond on Adila's question in terms of how do we hold the Department of Health accountable, and also the comment that Jonathan made with regards to us holding the Department of Health accountable. We have to, as civil society, ensure that we collectively write to the department to raise the specific issue. So it is something that I have raised within the department when I started to question the allocation of the money. I can say to you that 5 million of the money was at least awarded to the National Cancer Registry, who does not have enough funding to function. There's also a small allocation that has gone to Park Run. A very small allocation has gone to the Organ Donor Foundation. However, there is another institution that that already has a contractual agreement with the department that is situated at the University of Cape Town that have also received some funding. So there's some of this that has to be questioned. I am willing to, and I think this is what I need to put on the table. Adila, if you are willing to work with me so that we can, and others, and maybe Russell from your side, let's put a document together that we can then present to the National Department of Health, to the Director General, who I believe has been suspended pending the outcome of the court hearings. But irrespective of that, we also can share it with the Minister of Health. And I think that's, if we're not going to be proactive, it's just going to fall off the table again. So I've put my hand up for that one. Adila, I hope you will join me. Thank you.
Adila, I see you have just taken your mic off.
Agreed. Join.
Okay. Okay. I'll hand over to you. Yeah.
Can I just say, may I? I think what we need to do is we need to write a collective so that it comes from multiple organizations. But we need to look at more than just a letter. So I think that we need to also ask for audience with the Health Portfolio Committee, because they ultimately have to hold the department responsible. And we need to ask how budgets are being allocated and spent.
I guess my colleagues from RAP are taking notes on that. Yeah, something to follow up on.
Thank you. I agree with what our colleague just said. I think the letters that we've been sending to the Department of Health, I'm not sure that will move the needle. We need to be a bit more visible than that. We discussed and made the parallel with the HIV fight or the HIV situation. And maybe I'm wrong when I remembered, I'm remind myself that, yes, every year at World AIDS Day, the minister or the deputy president will say we have the biggest HIV program in the world and all that. It started with the Constitutional Court order. It was not out of the goodness of their hearts. No, we need to be sincere among ourselves. The Constitutional Court, as we say, the highest court of the land, has to put an order. Probably that's what motivated the ring fencing of the funds for HIV. So maybe we also should explore those avenues. We are blessed to be in a country where there's still some sort of separation of powers. So therefore, the judiciary might be a way of saying, this is the situation. An example, coming to diabetes. What the biggest complication of diabetes is amputations. Everybody knows that. Go to any facility, look at the patient files. You won't see mention of foot care being done to those patients, foot exams. Isn't it a case to be made that those amputees can lay a civil case against the government because the government guidelines say they need to have 1 foot exams at least a year. This is not happening and they get amputated. Who is guilty or who should be held accountable and pay for those people who lose their livelihood and now are staying at home, and once you get amputated, it's 3 years down the line, you are gone. So maybe we need to look at other ways, because my new thing is to say that old ways won't open new doors. We need to find, even as civil societies, new ways of putting pressure on the government. Does it mean judiciary? I agree also with the parliament thing. For the past 2-3 years, I've tried to get the years of the previous chairperson of the portfolio committee, Dr. Ndlomo. He has now been changed. There's a new portfolio chair. We need to have a sitting there where we put those data and those stories in front of those deputy MPs for them to react. And just in closing the head, one of the reasons why there might be poor spending of the allocation that we mentioned about, it's only 5 people in the National Department of Health who are responsible of NCDs. They go from World Health Day to World Health Day. World Cancer Day, they do something. Diabetes Day, they do something. Epilepsy Day, they do something. That's not a program. That's why they cannot spend money. They don't know what to initiate. The colleague spoke about the lack of tracking system and surveillance system. Yes, they are not initiating those programs because not only they don't have capacity, and they are stretched so thin. So yes, civil society we need to come up with strong, powerful new ways of putting pressure, and we need to do that to hold the government accountable. Thank you very much.
I like that we are almost wrapping up with practical ideas that are coming up. This meeting, in fact, in itself is just a step towards action, further action. So I think it is at the right time that we call to the fore Mapalane Mfundisi, who will do a closing for us, and hopefully also, and not tell us to go home, but perhaps, be clearer about what could be the next steps after this. Thank you.
Thank you, Program Director. I spoke to Candice and said, Candice, give me the takeaway points. So he told me that the speaker before me will do that. So those takeaways are there. The things that must be done are there. So I am just going to be like a politician and read the speech that I had written. As I was here, it was not prepared before. I was writing it as we were speaking, so that we get over and done and we go home. Salome Meyer from Cancer Alliance message must ring a bell, and that bell goes like this: where you live will determine whether you live. She reminds us that 84% of the population depends on the state to provide them with health services. She also reminds us that 80% of oncologists are in the private health practice. You don't need much to understand that South Africa is the most unequal country in the world. You live it daily. That is why we are meeting today in Rosebank, where those with opportunity and privilege live, and we are not meeting in Alexander or Tembisa or Kagiso, where the underprivileged and downtrodden live. Using the lens of the Minister of Finance, his choices are now influenced by serving the needs of those who eat caviar and down it with a single malt whiskey in Rosebank, avoiding being associated with the Heineken drinkers with nothing to do in Alexander, Tembisa, and Kagiso. The discussions of today, based on the topic of understanding health financing landscape and its options, need to reflect on inputs made on 1, prioritizing prevention and early management in South Africa's healthcare system, why prioritizing community health systems makes sense, and lastly, on why making cancer and by extension the non-communicable disease a district priority. At the center lies universal health coverage and national health insurance as the choice for South Africa to provide universal health coverage. The implementation of the national health insurance in South Africa represents one of the most important reforms in our democratic history. At its heart is a simple but powerful idea. Healthcare should not depend on your income, your employment status, or your postcode. It should depend on your need. We must link this advocacy to the legal battles that are going on regarding the NHI. This is another platform for us to go legal and defend what must benefit the people. To achieve this, we must integrate both our health services and our health financing. For too long, South Africa's health system has been fragmented. We have parallel funding systems, separate public and private systems, and vertical programs operating in silos. The fragmentation has deepened inequality. It has created inefficiencies and limited access for millions of our people. Integrated health financing under the NHI will change this. As we know, the NHI will pool funds into a single health insurance fund built on the principles of equity and solidarity. Those with greater means contribute more, and everyone receives care according to need. The NHI will, 1, replace duplication of coordination, out-of-pocket payments with financial protection. And I know as I speak, others are talking about the DG of Health. He is not the definition of the safeguards that we need to have with regards to money that is pulled together. If he chose to do what he did, he chose that, and he must deal with the outcomes of that particular process. Because many times people tell us that the monies will be in the pockets of those who want to loot it. If it means that we must send the bombs that are flying all over the world to him, that's what we need to do to protect the NHI and access to healthcare. A critical pillar of this financing model is the role of health taxes. South Africa already uses general tax revenue to fund public health services, but under the NHI, this approach becomes more deliberate and strategic. Progressive taxation that will include, but not limited to, personal income tax and reallocation of medical scheme tax credits will allow South Africa to build a national risk pool that spreads financial responsibility fairly across society. These pool funds must be guarded with all might so that those with corrupt ideas do not put their hands into this money. In addition, targeted health taxes such as levies on tobacco, alcohol, and sugary beverages should play a dual role. They should, A, generate revenue to strengthen the health system while simultaneously discouraging harmful consumption that drives non-communicable diseases. In this way, health taxes not only fill financing gaps, but also promote prevention, reduce long-term costs, and reinforce the public health objectives of the NHI. But integration is not only about money, it is about service delivery. It means strengthening primary health care as the foundation of the system. It means integrating HIV, TB, maternal health, cancer, mental health, and chronic disease management into one coherent, person-centered model of care. It means strategic purchasing, paying providers for quality and outcomes and not just volumes. Through transparent governance, strong accountability, and phased implementation, the NHI will build a system that is efficient, equitable, and sustainable. Ultimately, integrating health services and financing is about fulfilling the promise of universal health coverage and advancing the constitutional right to health care for all who live in South Africa. This is not just simply a technical reform. It is a moral commitment to dignity, equality, and social justice. This must happen in our lifetime. The battle must continue so that we transform South Africa. Our lives must not be determined by where we live and how much funds we have. It must be determined by living the preamble of the Constitution, which I want to remind all of us what it says. We, the people of South Africa, recognize the injustices of our past, honor those who suffered for justice and freedom in our land, respect those who have worked to build and develop our country, believe that South Africa belongs to all who live in it, united in our diversity. We therefore, through our freely elected representatives, adopt this constitution as the supreme law of the Republic so as to heal the divisions of the past and establish a society based on democratic values, social justice, and fundamental human rights, lay the foundation for a democratic and open society in which government is based on the will of the people and every citizen is equally protected by law, improve the quality of lives of all citizens and free the potential of each person, and build a united and democratic South Africa able to take its rightful place as a sovereign state in the family of nations. May God protect our people. Nkosi sikelele Africa. Morena boloka setjhaba sa heso. God sien Africa. Oh, God sien Africa. God bless South Africa. Mudzimu fatutsetsa Africa. Hosi katekisa Africa. That is the preamble to our constitution if we have forgotten it. As I conclude, Program Director, thanks to Tax Justice Network Africa, without whom this convening could not be possible. We also give thanks to Rural Advocacy Project, RAP, and the Health Tax Alliance for bringing us together. We thank all the speakers, physically present and online, for taking their time to prepare for this engagement. Most importantly, we thank you as the participants, both in person and virtually, for investing your time to make this convening a success. The message here must go to those who could not attend, but stand to benefit when what we advocate becomes a reality. Drive safely and have a nice rest. Thank you, Program Director.
Thank you so much for that. Yeah, thank you to RAP and to all the partners for this engagement. I imagine that the conversation will continue with the stakeholders that are in this room and beyond, that you'll be engaging on policy briefs, on advocacy together. There was a speaker who stressed the importance of collective action. There are good ideas that have come out, at least as suggestions on new initiatives that can be followed. I like the speaker who said something about old ways do not open new doors. And I think this is a message that really resonates and that keeps challenging us as civil society to do more, but to also think creatively about how we move forward. When we started this morning, we began with a moment of silence. We removed our attachment from positions, from status, from titles. We engaged in a human fellowship. As simple as we are, we come as we are. We live in a time that is unbelievable, in fact, that is difficult. Maybe not for us here, but I think you cannot, even if you are having a good time, you cannot divorce yourself from what is happening in the world. And because we are in times where you cannot actually continue to dream about a tomorrow, I want us to end this well and do so by just go to someone, turn around to the person next to you and wish them well. Tell them what it is that you wish for in their lives. Offer them a personal blessing. Can we do that? For those who are online, may you find joy, may you be happy, and thank you so much for being here.